Assalamu alaikum everyone. I'll be briefly touching the anatomical criteria for patient selection for performing an EVAR. So the learning objectives of today's presentation would include going through important terminologies and how to size an infrarenal AAA. Then I'll be touching the topics of conical neck and how to go about it. Lastly, I'll be talking about access site assessment and a few adjuncts. And the last part of the presentation would include going through commercially available specifications. So the major anatomic factor in predicting success with EVA is the suitability of the infrarenal aortic neck that includes its length, diameter, and angulation. The imaging modality of choice is obviously CT scan with 3D reconstruction. But to have proper sizing of the neck in terms of its length, diameter, and particularly angulation, image processing is required, and that can be performed by different commercially available softwares. Commonly used ones is the Aquarius Neck software. So we hear a lot about the diameter of the aortic neck and the aortic length. And interestingly, we only talk about the aortic neck diameter. So principally speaking, there are two diameters that require consideration. So one is the proximal aortic neck diameter. The other one is the distal aortic neck diameter. So what are these? So the proximal one is the aortic diameter at the level of the lowest renal artery. And the distal one is the aortic diameter just at the origin of the aneurysm. So the mean of these two distances is calculated, and this is known as the final aortic diameter, neck diameter. What is the aortic neck? Neck is the distance from the lowest renal artery to the point of the aneurysm where it originates. So this is known as the aortic neck length. What exactly should be the diameter or length? I'll come to the specific values or the objective values at the end of this presentation. After neck length and diameter, most important part is the angulation. Again, there are two components to it. One is the suprarenal neck angulation component. The other one is the infrarenal neck angulation. So first the suprarenal one. So it's basically an angle that is formed between 3 points. So we basically connect these 3 points where point A would be the center of the suprarenal aorta or the healthier part of the aorta. Point 2 would be the midpoint between the origin of the two renal arteries. And lastly, the last point would be the center of the aorta at the proximal part of the aneurysm. So this is a very good picture I came across on the internet. There are a few important points that they have identified. P1 here marks the healthier part of the aorta, which is considered to be the center of the aorta, which is above the renals. P2 is the midpoint between the origin of the proximal and distal renal artery. P3 is the center of the aorta at the origin of the distal renal artery. P4 is the center of the aorta at the proximal end of the aneurysm, that is where the aneurysm is commencing. And P5 lastly is the center of the aortic bifurcation. So to calculate the suprarenal neck angulation, we consider the P1, which is the center of the aorta, or the suprarenal aorta, the healthier part of the aorta. Then the midpoint between the origin of the proximal and distal renal artery, which is P2. And lastly, P4, which is the originating point of the aneurysm. So this is the angle between these 3 points. If we talk about the infrarenal neck angulation, here we consider different points. So the origin of the two renal arteries, the midpoint of that area, which is basically P2. P4, where the aneurysm is originating. And last point would be P5, which is the bifurcation. So P2, 4, and 5. This would make our infrarenal neck angulation. To simplify this further, so basically with angulation, what we want to know? We want to know the flow axis. So the angle between the flow axis of the normal part of the aorta or the suprarenal aorta and the flow axis of the neck. So the angle between these two is this suprarenal angle, and the angle between the other two flow axes, which is the neck and the main sac aneurysmal sac, the angle between these two flow axes is known as the infrarenal angle. Lastly, distal fixation diameter and distal fixation lengths. So the common iliac artery diameter should measure between 8 and 22 millimeter to have to be called as a good distal fixation diameter. The distal fixation length is the length of the normal diameter common iliac artery that is available to us, into which the limbs of the endografts will be fixed. Lastly, aortic tortuosity index. It is the difference between the center line and the straight line distance between the lowest renal artery and the aortic bifurcation. So there's a distance between the center line and the straight line. Straight line is the anatomical configuration on imaging, the normal lie that we see on the CT scan. So the distance that can be calculated between the lowest renal artery and the aortic bifurcation would be the straight line. However, the center line is again the flow axis that is a normal part of both of these areas, the aortic bifurcation and lowest renal artery. So the difference between these two, the flow axis and the straight line distance, is known as the aortic tortuosity index. The required endograft diameter is determined by measuring the aortic neck diameter. For example, if we consider it to be 20 millimeter or 2 centimeter, and then we should add at least 10 to 20% of the size, which is known as the oversizing. So if it's a 20 millimeter neck, then we need to add 3 to 4 millimeters to make it somewhere around 23 to 24 millimeter, the size of the endograft that would be suited to it. Oversizing to about 10 to 20% basically provides sufficient radial force to prevent device migration. What happens if we undersize this? So undersizing will lead to an inadequate seal and failure to exclude aneurysm, and there will be backflow, and the sec will again grow. With oversizing, obviously 10 to 20% of oversizing is good, but if you go beyond that, it can lead to inadequate expansion of the system, kinking, and on occasions, because of the inadequate expansion, thrombus can also form. Coming towards conical neck. So what is a conical neck? We hear a lot about this. So conical neck basically is a more than 10% change in the diameter or the neck diameter over the first 15 millimeter length of the aortic neck length. So for example, if the neck diameter at the level of the lowest renal artery was 20 millimeter, we go 50 millimeter quadrille to it, and it increases to, let's say, about 24 millimeters. Sizing, we already talked about it. It should be at least 10 to 20%, or the oversizing should be of 10 to 20%. So sizing for this would mean an endograph of 28 millimeters in size. But obviously, if we take a 28 millimeter endograph, this would mean 40% oversizing at the neck, which was 20 millimeters at the lowest renal artery. And obviously, we don't want further oversizing beyond 20%, so 40% is a bit too much. Or if a smaller size graft, that is, let's say 24 millimeters taken, that would be very much equal to the larger part of the aneurysm, which was 24. So again, the oversizing that is required of 10 to 20% will not be achieved. So this is the dilemma of the conical neck. So if we have more than 10% increase in the neck diameter over the first 15 millimeter length of the aortic neck length, this is known as the conical neck. So for these situations, it is important to split the difference so as to give at least a minimum 10% oversizing in the larger segment and a less than 30% oversizing in the smaller segment. The configuration would somehow look like this. The neck size was 20 millimeter. The caudal size at about 15 millimeter distance was 24 millimeter. So 10% would be equivalent to 2 millimeters, right? So if we take an endograft of 26 millimeter, this would give at least an oversize of 10% in the largest segment, that is from 24 to 26 millimeter, and an acceptable 30% oversizing at the level of neck, and it would be somewhere around 30%. So splitting the difference is a way to go about it if we have to encounter the conical neck. If the degree of size mismatch does not allow such sizing, for example, in a situation where there's more than a 3 to 4 millimeter conical change in the first 15 millimeters of the neck, EVAR is usually not advisable. The access sites for EVAR. So we can have open or percutaneous accesses. I will not be going much into the details of this, but there are two ways to go about it: percutaneous and open. Ideally, we should have control of both the common femoral arteries, because we need bilateral accesses for the contralateral limb to pass through the contralateral artery. Advantages of utilizing the common femoral artery, which is the most commonly used access route, includes relative, obviously, ease and the size of the access. The average diameter of common femoral artery in literature is reported to be 6.4 millimeters, with benefit of compression support against the femoral head at the end of the procedure if it is required. Common femoral access may become challenging in certain conditions that includes hostile groin, or in cases of significant obesity, occlusive aortoiliac segments, heavily calcified femoral artery, particularly with anterior calcifications, or having a high riding femoral bifurcation. Excess vessel diameters of less than 5 mm have been reported in literature with a higher risk of percutaneous aortic repair failure. So we should at least have a more than 5 mm size. The average size is usually 6.4, but there can be patients with smaller size vessels. So the distal landing zone. So the preferred distal landing zone is a common iliac artery, but external iliac artery can also be used for this purpose. Evaluation of this is similar to that of the proximal neck in terms of assessment with diameter, length, tortuosity, and degree of calcification and thrombus. The common iliac diameter should measure between 8 and 22 millimeters. The length of the normal segment of common iliac artery should be at least 15 to 20 millimeters to have an adequate seal. Um, uh, and if we are to use external iliac artery, a minimum diameter of 7 millimeters is needed to allow the passage of endograft delivery sheaths. There can be cases, particularly where we can have concurrent common iliac artery aneurysm with AAA, and literature suggests that there can be 20 to 30% of such patients. This requires extending the stent graft length past the aneurysmal common iliac artery and into the external iliac to obtain a distal seal with embolization of the FC lateral internal iliac artery. So basically, we are occluding or we are bypassing this segment of the common iliac artery that is aneurysmal. There can be problems with internal iliac embolization. Unilateral embolization is generally considered safe, but patients can have sexual dysfunction or buttock claudication in about 20 to 50% of the cases. There are different rates that have been reported in literature. Bilateral occlusion is traditionally considered to carry a higher risk of severe pelvic ischemia. Interestingly, the literature that we have available does not suggest a statistically significant difference between unilateral versus bilateral embolization in terms of symptomatology. Embolization may not be necessary if there is severe stenosis at its origin, since stent graft coverage across its origin will allow it either to thrombose and prevent endoleak formation. Focal narrowing and mild angulation of common iliac can be overcome with standard guide wire and catheter techniques. If with diffuse narrowing the device fails to pass, we can form an iliac conduit. This again is a separate topic in itself, but what is an iliac conduit? So here what we do is, because of the narrowing, if we are unable to pass our system and the device, a separate uteroperitoneal incision can be given where a 10 mm PTFE graft or a Dacron graft, depending upon the availability of the inventory, we can anastomose it with the common iliac or if need be with the aortic valve, and through this we can pass our devices. This is a picture of a concurrent aneurysm where there was an infrarenal AAA along with right side common iliac artery aneurysm. The arrow denotes that. And after performing successful embolization of the internal iliac on the right side, here we can see we cannot visualize the internal iliac. However, on the left we can see it. After embolization of that, stent graft system was passed, and this common iliac aneurysm was excluded from the system. Lastly, a few adjuncts. So current anatomic recommendations propose a minimum diameter of 20 millimeter at the aortic bifurcation. Potential risks in patients with narrower aorta include arterial dissection, disruption, thrombosis, difficult gate catheterization, particularly from the opposite side, or stent graft compression and collapse. However, recent evidence suggests that EVAR can be safely performed even with less than 14 millimeter aortic bifurcation, and significant data suggests that at least for less than 18 millimeter aortic bifurcation, it can be performed safely. A patent in inframesenteric artery with two patent L3 and L4 lumbar arteries are independent predictors of an increased risk for type 2 endoleak after EVAR. So embolization of these IMA and L3 or L4 arterial occlusion is considered to be protective against the occurrence of a type 2 endoleak. Lastly, so the important values that we should know when we are sizing the aneurysm and talking to vendors in terms of specifications. So the minimum suprarenal angle for all devices. So basically, there are different type of devices, 7 to 8 that are commercially available. The commonly used ones are the Cook Zenith system or the Medtronic Endurance systems, which are the two most commonly used ones. And lastly, there's another system which is the Excluder system made by Gore Company. Unfortunately, I'm not sure, but I don't think it is available in Pakistan. So for suprarenal angle, it should be less than 45 for all devices, and the infrarenal angle should be less than 60% for all these devices. There are few variations in terms of length and neck diameter. So for neck length, that is from lowest renal artery to the neck, it should be at least more than 15 millimeter for the Zenith or the Cook system. For the Medtronic one, it should be more than 10 millimeters. Neck diameter is more or less the same with some variability. Largely speaking, 18 to 32 millimeter is good enough for all the devices. Zenith says that it should be 18 to 32 with a few here and there tweaks here and there for endurant and excluders. Similarly, for distal fixation length, minimum should be that it should be more than 10 millimeters. Endurance suggests that it should be more than 15 millimeters. And for diameter, 8 to 25 millimeters is good enough generally for having a good distal fixation. Thank you. This was about the anatomical selection criteria for EVA.
Thank you, Ammar. That is excellent presentation. If there's any comments or questions, you are welcome.
Thank you, Ammar. Can I comment something?
Sure, sir.
So, Ammar, thank you for this nice presentation. It's a very important aspect of EVAR for the anatomical criteria. You have pointed many important things regarding the neck, the conical neck, and landing sites as well. One or two things which I think are worthwhile discussion. One is the thrombus and the calcification at the neck site is an important factor when discussing about EVAR. So the presence of extensive calcification or the extensive circumferential thrombus at the neck is a sort of I would say a red area that you should be aware of, that how should we deal in such patients. The second, it's important to go through that. The second is you have discussed about the conical neck. There is also a reverse conical neck, I mean, which is called funnel shaped neck, that just below the renal artery, you have a diameter which is slightly higher, and where as you go closer to aneurysm, the diameter becomes a little bit less. So it sort of becomes funnel shaped neck. So how can you deal with that? That is also another important aspect to discuss. Then if we talk about the anatomy of the aneurysm, you rightly discussed about the size of or the diameter of the neck, also the diameter of the aneurysm, but the diameter of the bifurcation is another important aspect to consider, because if the diameter of aortic bifurcation is too less, probably, and it should be adequate enough uh, to make sure that the both of the limbs of the endograft, they can sit nicely in that bifurcation. Otherwise, you can result in a kink or compression on one of the limb, which can cause acute occlusion and leg ischemia. So the adequate bifurcation of the adequate diameter at the bifurcation is another very important aspect to look for. I think it should be at least more than 20 millimeter mercury. Distal landings zones, you said they were okay. Tortuosity is mainly concerned with the external iliac arteries because many of the time they are tortuous, and that should be kept in mind when you do the straight lining or center point, making the center point via the softwares. And that can be because once you put the Lindequist wire, all the tortuosities are gone, and then the sizing at that time is not a good idea. So it has to be a preoperative thing, which you must have done before the procedure. Access site related things, the maximum least diameter of common femoral artery should be at least 7 millimeter for either open or percutaneous, because if it is less than 7 millimeter, then your endografts or the delivery system will not go from the common femoral artery. So the least diameter should be at least 7 millimeter mercury, 7 millimeter in common femoral artery. So these are some of the important points. And then in adjuncts, you can discuss about the stapling device or the aptus device for conical neck. But I think that's beyond the scope of this presentation. But it was very nicely presented. Thank you.
Thank you, sir. Sir, if I may ask a question, Dr. Zia, you or anyone else can answer. So, sir, books usually suggest that the femoral for excess should have 7 millimeter, as you mentioned, diameter. But I was going through literature, and people they have mentioned. I'm sure this is not a level one evidence, but there are reports that people are performing these procedures with even lesser diameter. So there are 3 to 4 studies that have recommended that at least it should be more than 5. Below 5, they say that there is proven adverse outcome, and 5 is the last cutoff. But the gray area of 5 to 7, it has been explored, and few people are performing these procedures with 5 to 7 millimeter diameter of the femoral artery. Even though I completely agree, the book suggests that it should be 7 mm. Similarly, for aortic bifurcation, yes, it should be more than 2 centimeter or 20 millimeter. But there are a lot of studies where less than 18 millimeter, that is somewhere around 18 millimeter of aortic bifurcation size, EVAR has been done successfully, even though the level 1 evidence itself suggests it should be 20 millimeter. So I'm just a bit curious that we should be following the level 1 evidence that is available, that is written in the books. But yes, there are a few modifications because the devices are improving, and with technology everything is obviously growing. So the exact measurements may not be applicable as we move along with time, and things might change. So these are two things that we need to consider, that people are performing these procedures with even lesser diameter, slightly lesser diameter.
Yeah. Thank you for your comment. Any comment from Dr. Nadeem or Dr. Ilyas or Dr. Sheikh?
So, Amar, yes, you are right. I completely agree. And as the EVAR has evolved, um, people have gone into the territories which are sort of controversial or the less comfortable for the surgeon. But two things you must remember, that first and foremost is what device you are using and what are their usage instructions. And you should always stick to their IFOs when whatever the device you are sticking. There is one device which we have used. It's called Triflex, something which have been used in the common femoral artery of 5 to 6 millimeter mercury. But generally for Zenith and Endurant, they do not recommend 5 millimeter mercury, 5 millimeter vessel size. So yes, people have done. People even have started to put EVAR in diameter of one neck length of 1 centimeter. Um, but at your level, you should be knowing the basics, that what is the least minimum thing which should be there, and what device you are using. You should adhere strictly to their instructions. This is what my take is. People have explored many things. I agree.
Yeah. Thank you, Dr. Nadeem, and this is a very nice comment. And, I appreciate Ammar for presenting such a nice presentation and good comment. Actually, the goal of whole this planning is to prevent the endo leak, and they can occur as early and they can present as late. Endo leak is a failure of procedures, and the more the adverse anatomy, the more their chances of getting the endo leaks are there. And there are many factors. For example, you have noted that is length, which matters. Then there's a diameter of the neck, it should not be too large. Then, as mentioned, there is a role of angulation of the neck. Then we always consider the calcification and thrombus for there. But more the adverse factors are there. For example, there's a neck which is relatively short, it is calcified, it has thrombus, it has more risk of getting endo leak, and there is going to be expansion of the aneurysm, and aneurysm is going to rupture. So it is not nice idea to do standard EVAR there. But and same is true for the iliac tortuosities, means if the iliac vessels are aneurysmal, you have less landing zone, there's a kink, and there's more of calcification, more the adverse factor, there's more chances of 1B endo leak. So yes, you can take one adverse factor for that, but you cannot add more of adverse factors. People have been using these EVARs beyond IFU, but for the starters or the beginners or the centers which have lesser experience, there's strong recommendation they should stay within the IFU. Then there are graft specific modification. For example, some of the grafts can be used in an angle of 90, but definitely for these patients, standard EVAR, we said the angle should be less than 60. Then there are stent grafts, which can be specially meant for the length of less than 10 mm, and just like endurance. But for the standard, we say it should be at least 15, because the studies have shown the people who have 2 centimeters, 2 centimeter neck length and without any calcification or thrombus in the state one, they have less chances of endoleak. Then there are stent grafts which are made with without considering the neck anatomy. For example, there is a stent graft which is actually using the polymers, which actually fill. It is Nelix system, which does not take account. It fills both of the aneurysm anatomy. And when you compare the data, the patients who have undergone EVAR beyond the IFU have more of endoleaks, and that is a point which I wanted to raise. So you have to be very specific when you are calculating, checking the neck at first factor for the side anatomy and this one. Thank you. Maybe
Thank you, sir, for the valuable input, sir, Dr.
Yeah.
Nadeem and Dr. Zia.
Yeah.